All right, good afternoon, everyone. Welcome to our weekly webinar. This is our last weekly webinar for 2023. We will take a break after this week and we will return on January 11th, 2024. I've already started scheduling speakers for the first quarter of the year, and we've got some really exciting and informative topics coming up. Thank you all for being here, and so many familiar faces or names on the screen. This past Tuesday, December 12th, was my 1-year anniversary of working at the ADRC, and it's been a real honor and a joy for me to be with you. So thank you. Thank you for your participation in my alliance. Thank you for your participation in research and all of the programs and services that we are working to bring you the very best care and ultimately the cure and prevention for Alzheimer's disease and other dementias. So with that said, I see some more folks joining. So I'm happy to have everybody who comes in as they come in. As always, our housekeeping notes. Looks like everybody's muted. Thank you. Please keep yourselves on mute while our speaker is presenting. Use the chat function if you have questions or comments. And we are recording. And I pledge to you that this recording will be available by tomorrow, so that it will be available for anybody you think might find it useful. And all of the other recordings for all year long are also now available to watch. So if you need something to do next Thursday, we won't be here live, but you can certainly go back to previous webinars from 2023 and revisit or find one that maybe you didn't get a chance to see the first time around. So stay tuned for that. And if you need closed captioning, the closed caption button is at the bottom of your screen. Feel free to turn that on. And I think those are all the housekeeping announcements for right now. So with that, here is our speaker, Dr. Autumn Brubaker, who is a physician specializing in geriatric and internal medicine. She is a graduate of Kansas City University for medical school, and she did her residency and fellowship right here at KU. Dr. Brubaker is an assistant professor at KU Med, and she sees patients also at an area skilled nursing facility. She teaches medical students in the areas of internal and family medicine, geriatrics, hospice, and palliative medication, hematology, and oncology. So Dr. Brubaker is quite well suited to talk with us today about advanced care planning, and we are delighted to have her in her spare time, and I hope you get as much of it as you want, Dr. Brubaker. It sounds like you've got a full calendar, but in her spare time, she spends time with her husband, their 2 kids, and does acrylic painting and gardening. So what a wonderful list of talents you have, and we are looking forward to hearing about advanced care, Dr. Brubaker. So I will turn it over to you. Thank you.
Thank you so much for that kind introduction. I am going to try to share my screen here. Bear with me one second. All righty. Okay, are you able to see that? Perfect. All right. Well, thank you, everybody. It really is a pleasure to join you today and talk about what I consider what matters most, and that's the advanced care planning. So hopefully by the end of our conversation today, we'll at least have an understanding of what advanced care planning is, what considerations should be made when preparing an advance directive, as well as choosing a durable power of attorney for healthcare. Does that cover up? I'm not sure if you can see the other piece of that. Okay. So what is advanced care planning? So advanced care planning, it really is a process. It's a process about learning what decisions should be considered about your health care and even end of life care wishes and discussions. You want to make sure that you're having discussions also not only with family and friends, but with individuals of your healthcare team, and those that you trust. Like I said, with families and friends too. You want to make sure you're documenting your decisions with an advanced care directive or living will. That's another terminology there. And electing a durable power of attorney. And we'll talk more about those pieces here shortly. We want to make sure that we are sharing information with our durable power of attorney for healthcare, your medical team, as well as others that you want to know about these wishes and your decisions that you've been making along the way. The last step of this is an ongoing step. I consider an advanced care plan, and that is a really kind of a living, breathing body of work for you. We want to make sure that we are reviewing that to make sure all of those decisions that are made and documented really continue to align with the goals that we have as we progress through life. So let's get started. So advanced directives, there is there's a couple different terminology out there, and because there's some variability on living will definitions as well as advanced directives, I'm going to be using the more general term advanced directives for the purpose of our conversation today. And just to be mindful of it, a living will is a type of advanced directive. So, okay. So why is it important to complete an advance directive? Completing this allows your voice to remain the voice for your healthcare decisions and end-of-life decisions when you're not able to make your wishes and preferences known and not able to advocate for yourself. Additionally, it takes that burden of the decisions off of your family members and allows them peace of mind, knowing that you're being cared for exactly how you want to be cared for. Often when I'm having conversations with my patients and their caregivers, the conversation shifts to what's the right time for this to be done. The short answer is anybody, any adult over the age of 18. I think Alabama has 19, but um, they can complete and should complete an advance directive. When you are experiencing memory changes, especially if you've received a diagnosis of mild cognitive impairment or dementia, it's really important to have these conversations and complete documentation early on to ensure that your wishes are carried forward. Also, you want to reach out to your medical team and have conversations and think about what medical conditions you have and any recommendations that you have previously received from your healthcare team, too. Other considerations as we talk through this is especially important to talk about cultural or potential religious considerations, especially if your durable power of attorney does not share those same views as you. So you can have those conversations and gain understanding and common ground. A couple of things that I thought of as I was preparing for this conversation today was blood products. Is that something that you would or would not want as a blood transfusion or plasma derived medications? Other are porcine devices or medications too. Next, I wanted to shift gears a bit because it's important to understand and think about what life support or life sustaining treatment actually means to you. Things like if you're not able to eat or drink on your own, would you want those provided to you artificially, like artificial food or water that's provided by a medical device? Would you want blood transfusions? If your kidneys were not working and filtering your blood and keeping you healthy and strong, would you want temporary or long-term dialysis? Would you want antibiotics or medications to help support your blood pressure? Medical devices to help you breathe. Oftentimes we start thinking about that and we think about the ventilator with a tube down your throat to help force that air in and out. But this also could be masks and things like that can, if you're claustrophobic, that was one of them. My patient said, I would never want that because I just can't handle that from a claustrophobia standpoint. And it's an important thing, especially if you're not able to advocate for yourself, to include there too. And then we think about things like, would you want CPR or some of those advanced heart failure interventions? Would you want to limit interventions? If interventions were already started, would you want to have a time frame that you would say, I'd only want X amount of hours or X amount of days to try to see if this will help me? Are there circumstances that you would or would not want life-sustaining treatments? Another consideration here is, would you want different interventions based on what progression of disease you've had or stage of dementia? In mild dementia, while memory changes make it often more difficult to do routine tasks, you're often able to care for yourself and do the personal cares like eating and bathing and toileting. Would the decisions made for that stage look different for you if you were more dependent on your caregivers for those personal cares as you advance in dementia processes? An underutilized code status is the do not hospitalize. And that's one that can be elected. It's not an absolute, but what it does is it says, I want to focus on treatments and cares that can be provided outside of the hospital rather than continuing to go back and forth to the hospital itself. Now, like I said, it doesn't have to be absolute. So you can make stipulations and say, hey, if I have profuse bleeding or chest pain, or heaven forbid I've fallen and had a fracture, those types of things that would warrant going to the hospital can still be done. You get to make those decisions. If you are one that would want to be left in your natural state, if you were to stop breathing, or if your heart were to stop, the consideration there would be an election of a do not resuscitate or a do not intubate. And these are where you would not have CPR, those chest compressions. If that is your decision, and that's what the direction you'd like, I do encourage you to talk to your primary care physician. They can fill out a form, which is a transportable. So it's the short term is TPOP, but a transportable physician order for your patient preferences. And so this is usually a very brightly colored form that you fill out in your doctor's office, and it's something that you post on your fridge. Our emergency medical teams, when they respond after you called 911 to your home, they're trained to go look at that refrigerator and see if you have one of those so they understand what interventions you would or would not want to have. The other consideration there would be if you do want to do not resuscitate, getting like a medical alert bracelet that would also communicate those preferences when you're out and about in the community. And then lastly on here, I've included organ and tissue donation if that's something that you would want to consider. Shifting focus now to more of those end of life and comfort focused care directives. It's important to understand what options are available from a hospice standpoint and what support they're able to provide from a medical, emotional, and spiritual care perspective for you as well as your loved ones. Thinking through if you'd want medications for pain or medications that would help you from an emotional distress or a physical distress standpoint. Um, what I'm thinking of here as far as the emotional distress is if things like a depressed mood or distressing hallucinations that may be present. Physical distress may look like shortness of breath or difficulty managing our secretions. It also can be things like nausea and vomiting and that. If you are a spiritual or religious person, thinking through if you'd want to have readings done or visits from different clergy or those in your faith community as you're nearing the end of life. From a documentation standpoint, there are different state considerations to account for. Kansas has wording on their website as far as having a government approved form and being able to express your words and your own words on that type of a form. If you visit the Kansas State website, they do have a lot of links to be able to look at their forms and that. Additionally, if you're doing living wills and those things that you don't need to use that type of a form. Now, Missouri residents, they do require a notarized signature on advance directives. So please keep that in mind so that there's not any problems later on. As far as, again, early in our conversation, we were talking about continuing to review our documentation, and that includes with advanced directives. So it can be changed. We want to make sure that we're reviewing it so that we're aligning our goals with our current views. And it also can be revoked at any time. It does go into effect the moment you're not able to make decisions for yourself and communicate your wishes for yourself. The advanced directive, as well as your durable power of attorney for healthcare, which we're going to talk a little bit more about here shortly, those two will help guide the care if you're not able to advocate for yourself. So the durable power of attorney for healthcare. The other short term is DPOA for healthcare, a little less of a mouthful. This is a specific designation for a decision maker for your healthcare needs if you're not able to advocate for yourself. This is separate from that general durable power of attorney, and that document does not include healthcare decisions and is more the financial side of things as well. And kind of the reverse of that, the DPOA of healthcare does not cover any of the financial and estate matters, just the medical. So there's two different things. And I'd encourage you to have both of those. But for our purposes, we'll talk about the healthcare. So who can be your DPOA? Really, it's anybody that you trust. It can be a family member or a friend that knows your personal, emotional, and spiritual beliefs. Someone that you feel confident will respect and advocate for your wishes, even if faced with decisions that are not outlined specifically in your advance directive. And you're confident they will make consistent decisions that align with your goals and values. You want to make sure that you're disclosing your intent to have somebody as a DPOA for healthcare and asking if they're comfortable performing in that role. It's not uncommon for me to see in the hospital where family members are uncomfortable with that decision or making those really difficult decisions, and being able to have that conversation ahead of time to understand, is that something that you would be comfortable doing? Because sometimes those closest to us are too emotionally involved to make those decisions. Additionally, so you can elect for obviously the primary DPOA, but you can also have alternate DPOAs selected so that if your primary person is not available, you have other people that can step in for you and make those decisions. Again, I've mentioned it a couple of times, I think at this point, but make sure that you're reviewing your advanced directives with your durable power of attorney for healthcare and update them with any revisions. The big piece of this is it allows them, if you're outside of a time of distress, having those conversations, allows them to have a little bit more of a question and answer moment with you to make sure that they really are understanding what your wishes are. So who cannot be your DPOA? That's another important piece to talk through here. Anybody in your healthcare team here, you can't have your primary care physician, an employee of that physician, or the spouse as one. If you live in a facility, it cannot be an owner or operator of that facility either. Anybody that has a vested interest from that healthcare standpoint. The last line on here, that last bullet point, is if it's somebody that's already serving as a proxy for more than 10 people. I'm thinking about the situations that they may be guardians or conservators for other people. That would be somebody that you may think about somebody else. You can have it if they're a close spouse, if they're a spouse or a close relative, but be mindful of that detail too. So decisions that your durable power of attorney for healthcare can make for you. So they interpret the instructions provided in your advance directive. They can authorize or refuse medical care and services, including tests, medicines, procedures, or surgeries, and including and up to those life-sustaining treatments that we talked about. If treatment has already started, they can make the decision to keep it going or to have it stopped. They can consent for you to go to the hospital, to be admitted to an assisted living facility, nursing home, or hospice.
I'm gonna might pause them for another 20 minutes.
So they can also hire or fire any caregivers that are involved in your care. They also can sign medical documents that authorize release of medical information as well. If you require care that is provided outside of our state or our system, that they can move you to another state to provide that care. But keeping in mind that it's only for the healthcare part of it. It's not including the financial piece unless they're also that general durable power of attorney. They can authorize the tissue and organ donation, and they can apply for health insurances on your behalf. Now, just like everything that you've made decisions on with the advanced directive side of things, you can also limit or add additional powers for your durable power of attorney of healthcare too. So when would these powers, all of these things go into effect? If you are not able to make decisions for yourself, that could look like progressing cognitive impairments, also acute illnesses or injuries that result in confusion, or a condition where you're not conscious or you're not able to meaningfully respond. If your treating physician does not feel like you're able to make these healthcare decisions, the other term would be lack of capacity. Um, at that point, they will ask a second healthcare provider to come in and assess. And if both of them agree, that's when your durable power of attorney for healthcare is activated. If you change your mind, you no longer want that person to be your DPOA for healthcare, you can revoke and revise this. If you want to completely revoke the entire document, you destroy it and make sure that all copies are destroyed, and including reaching out to your healthcare team, because I'd hope for that to also be a copy at their office. We want to make sure that they have the most up-to-date information, so that they are prepared and have that in their back pocket. Hopefully not need it, but we want to make sure that they have the most up-to-date information. If you are just revoking one of your like your alternate DPOAs, you would just write revoked over it and sign it. Keeping in mind that if they are requiring notary for other documents, like in the Missouri side of things for notarized signature, that also would be something to have there too. And that's what I have for today. I definitely appreciate the time to come in and speak with you. I'd love to hear any questions.
Perfect. Thank you so much, Dr. Brubaker. We have two questions that just came up in the chat. So I'll start with the first one and read it aloud so everyone can hear and give you time to think about an answer. And the first one is from Elaine, who asked, what can you do if you have no one to be your DPOA?
That's a very good question. So, oftentimes we start thinking about family members as our first line of asks for DPOAs. If that is not an option there, thinking through other people that you trust, that can be neighbors or friends, and trying to establish if there's other people in the community. It is the challenge comes is when you don't have one elected, especially when we're in that time of need. I would implore you, if you've got other communities or social groups that you're involved in, trying to identify key people that could potentially fulfill that role, and you could have a conversation with them. Hopefully that helps.
Thank you. Cheryl wants to know if there is a way to indicate that you wish to have your body donated for scientific purposes for emergency responders to see. Does that fall under organ and tissue donation?
As far as emergency responders, you probably could have that included. I'm trying to think back through what the short term is TPOP form. I'm not sure if it's on there. Certainly, you can have that designated on your advance directive, and that is a fantastic place to have that on there. I know that we've got the designations like on our driver's license and things like that for organ and tissue donation, but not specifically for that scientific purpose. I would, like I said, encourage you to do it through the advance directive and communicate with those around you so that that is a common knowledge that that's your interests.
Yeah, that's really important, particularly for organ donation. And I think a lot of folks watching are probably maybe interested in brain donation. And we know for sure that that's got to be something that's arranged for well ahead of time. So
Yeah,
just like that. Okay,
yes.
Peggy wants to know where do we get the form for DPOA? Dr.
So
Brubaker, you mentioned the websites, I think, of Kansas and Missouri.
there are, yes. So I know for at least when I was doing outpatient work through KU, we had a document that was nice. It was called the 5 Wishes. They do have a website for it as well that kind of helped walk you through some of these conversations. There are some general DPOA papers and paperwork online. But even at your primary care doctor, usually we have some just kind of general forms that you can elect for that and get it signed there and already scanned into your chart too. So.
Okay, I'm going to drop in the chat. Some of you may be familiar with the Center for Practical Bioethics here in Kansas City. And they've got some nice materials about these documents and called Caring Conversations. And actually, I just looked at their website and they have the T-pop that you mentioned,
Perfect.
Dr. Brubaker. So I will
Perfect.
keep that link here in the chat. That's not necessarily an endorsement. I think you're fine to use them. That's just one of many resources. I
Absolutely.
think your local library probably might also be a good place to find some of that documentation. And they have copy machines and emails and faxes too. Okay, gosh, you guys have some great questions.
This is great. I love it.
Charlotte wants to know what you can do if the treating physician does not honor your DPOA.
Interesting. So making sure that they actually have the paperwork in hand. So sometimes we have situations in the hospital where we're unclear who the DPOA is, and it tends to be more kind of word of mouth. And so we want to make sure that we have the documents with at least provided at some time during that hospitalization. And hopefully we can get that scanned in. It really comes down to they are the ones that making the surrogate decisions. As a physician, we want to make sure that we're providing information so that you can make informed decisions. But certainly we want to make sure that once that information is provided, that we are also honoring those wishes too. So it can, if there is a situation, there are ways to escalate that if you're in the hospital. And certainly those are things that you can ask about at the bedside with either nursing teams or other providers too.
Perfect. Okay, let's see. From there, we've got Beth who wants to remind us, yes, KU does have a program and paperwork for donating one's brain or a loved one's brain. We do have that, and there's some very specific steps to take and things to put in order. So if that's something you're interested in knowing more about, you can send an email to myalliance@kumc.edu, and I'll be happy to share information. Michelle is asking whether the power of attorney ends upon the death of a person, or can this person handle funeral, banking, etc. after the person dies?
So all of those financial and estate pieces goes to a general durable power of attorney. It would not, outside of the organ and tissue donation piece of that, at death, that everything else would go towards the general power of attorney.
Okay, very good. You all are on it. These are all great things that I'm not sure we all would be remembering to think of in the moment. So thank you.
This
And
is
this is
wonderful.
why we record these. So if you're scrambling, trying to write everything that Dr. Brubaker is saying, if you're trying to write it all down, know that it will be in the recording. And I will have access to, I'm not skipping anybody, but Renee asked if the chat message and the links come through on the recording. So I know that I can see them having access to the KU Zoom account. The chats won't be on the recording, but if there's a link or something you missed, I do have access to the chat after the fact. But we don't include the chat in the recording. Okay, so hopefully that gets you what you need, Renee. Okay, let's see. We've got, make sure to complete the homestead portion of the DPOA if you might need to sell your home. So all of this has lots of moving parts. Is that fair to say? So it's not just about how you want to be in the hospital. It's all about kind of getting your affairs in order, how to make sure you take care of everything in the way that would be most meaningful to you. So great point. Okay, let's see. And have a payable upon death is what POD is my memory supporting me. POD and TOD for automobiles and homes. Yes, okay, and transferable on death. I think those are correct.
Okay.
Okay, thank you. And let's see, Diana says, Vermont Vale Hospital in Topeka uses hospitalists, so the primary care physician doesn't supervise the hospitalization. How can I make sure my DPOA reaches the hospitalist?
That's a great question. We have a similar setup also with KU, where it's not often that the primary care physician is coming into the hospital too. So that's where it's great because we share the same system, and we can see once the DPOA paperwork is scanned in that transfers across. If you do not have, if your primary care physician is not affiliated with Stormont Vail, it would be making sure that you present to, typically, I would assume would be their registration office, something along those lines, to be able to have it scanned in. If you are going to the hospital and you're anticipating to be admitted, making sure you go with that document, or a copy of the document goes with you so that it can be scanned in with your admission.
Very good. Okay, my chart. Yes, I think my chart is something that we have all had some interaction with
Yes,
at
yes,
some
yes.
point. Technology is wonderful, isn't it? Especially when it works well for us.
Yeah.
All right. So that is, thank you for the well wishes for, I'm glad people have found today's program useful. I had every expectation that you would. And gosh, as we're winding down our time, I'm thinking, what am I going to do next Thursday with my half an hour or so between 2 and 3? I'll be thinking of all of you. And actually, I'll probably be working on the speakers for when we come back. So I will be occupied. I'll miss talking with you all and seeing you all. Do we have any other questions for Dr. Brubaker or for me, or any other comments before we wrap up? Never has time flies been more appropriate. I don't know that I can say we've had fun, because this is not necessarily a fun topic, but it is so meaningful and so important. And I'm so glad that you all took the time to be with us. And if anybody is watching this like 2 weeks from now in the future, we're glad that you watched as well. Thank you so much. And I don't see any hands raised. Elaine's got a thumbs up, so Dr. Brubaker, make sure you see that. And I've
Yes.
also gotten a couple of messages that just came to me, Dr. Brubaker, that says this was really, really helpful. So I'm passing that along to you.
Thank you. I really have
And
appreciated the time an opportunity to spend with you guys today. This is, like I said, this is a what matters most in my
yeah,
view. So I appreciate the time.
absolutely. All right. One or two, probably just one last thing. A couple of you have sent me some really great ideas for topics you'd like to see in 2024. And I really appreciate that, because I always want to be able to bring people what they're interested in. So if you have an idea for something, please send an email to my alliance at kumc.edu, and I will do my best to find a speaker who can address that. I've had a request for sleep apnea and brain health. And I've had some requests for activities and behaviors at home. So your wish is almost always my command. And I'll be happy to arrange for that. That being said, just got another one in a private message, duly noted. I will put that on my list. And thank you all again for being here. And when we wrap up, I'm going to start uploading this recording to the YouTube site so that you can have access to it again. Have a great holiday, everybody. Enjoy the time. And we will see you back on the My Alliance newsletter will continue, and the webinar will return on January 11th. Okay, take care, everybody. Bye-bye.